Hello, everybody, and welcome to our latest NCSA webinar and slash podcast. I'm Jill Escher. I'm your host today, and this is the latest in our webinar series, which we also repurpose as a podcast, both on YouTube and on our podcast audio-only platforms. I know that's been a little bit confusing for people. But we haven't had a lot of standalone podcasts this year. We've been repurposing our webinars. And I'm sorry that those of you who are listening on audio can't see the slides, but I do refer you to our YouTube channel where you can be able to see everything on this webinar and previous webinars. And I will make sure to put that in the show notes. Okay. So thank you so much for your patience with us as we kind of do this double effort to repurpose our work here. And our podcast, we have gotten a couple of people emailing us saying, like, when is the regular podcast going to come back? It will come back. It's just been a very, very busy season, and this has just been the most efficient way to bring you really the best and most important information. And speaking of important information, today we are very, very, very happy to be presenting on an issue that's hugely important to many families facing severe and profound autism, and that is crisis care. I know my family was in the situation where we were desperate for care when our son went behaviorally off the rails. It's very common to see this need, unfortunately. And we have really somebody who's so incredibly well versed in this issue, both from a professional and personal angle. And that is our guest, Arzu Forough. We're so happy to have Arzu because she is really a legend in the autism community, not just in Washington State where she lives and works, but really around the country. Everybody knows her, and she's very well respected for her incredibly diligent work, expanding not only what's offered to autism families in the state of Washington, but also nationwide, through her work on the ACA and also through her work on Medicaid. She will give you more details about her background, but she is president and CEO of the Washington Autism Alliance, or WA. Love that. WA. And I have the good fortune to personally know Arzu. I've met her on a couple of occasions, and recently we traveled to Washington, D.C., where we joined with some fellow advocates in meeting with staffers and congresspersons on the Hill to try to make some meaningful change in federal law and regulation affecting our population. So with that introduction, I'm going to turn it over to Arzu. And as you guys might know, go ahead, use chat all you want, but I really prefer to use Q&A for questions because it's hard for me to toggle between Q&A and chat. So feel free to use both, but I will be looking primarily at Q&A. And most of the questions will be held to the end probably, but if there's anything that I have to interrupt with, I most certainly will. With that, Arzu, welcome.
Thank you very much, Jill. As some of you might know, I am the proud parent of two on the autism spectrum, both of whom with co-occurring mental disorders. One of them has significant developmental and communication delays and a long history of severe challenging behaviors. I founded Washington Autism Alliance, or WA, in 2007 out of personal necessity in order to prepare Washington State for lifelong support of people like our sons. But when it comes to supporting those with profound autism and co-occurring mental disorders, we're definitely not there yet. We provide legal services, individual case management, and multi-system navigation, and a robust training program for individuals and families throughout Washington State. As Jill mentioned, if I say something and you have a question that you want to ask right about that slide that's on the screen, please go ahead and put that in the Q&A. People with profound autism rarely have access to evidence-based therapies, interventions, and services. The structure and predictability of school programs, as well as the care coordination and arranging for medically necessary therapies, are halted once these individuals turn 22 years old. Most families and guardians are really unable to replicate the structure, predictability, and consistency that therapeutic programs offer. It is in absence of these vital services that profoundly autistic individuals develop behaviors that jeopardize not only their own health and safety, but also of those closest to them. And this further leads to isolation and restrictive placements. It is going to take all of us working together to reverse this trend. But there are some near-term solutions towards crisis stabilization while we're working with more systemic reforms. This presentation is focused on the near-term solutions. First of all, who are we talking about? We're talking about autistic individuals who have an intellectual and developmental disability who are experiencing a mental or behavioral health crisis. In Washington state, as well as other states, these individuals meet eligibility criteria for services that are funded through the Developmental Disabilities Administration. In your particular state, that agency might have a different name. And these are individuals who are experiencing crisis in form of mental or behavioral health, aggression, property damage, self-harm, psychosis, etc. That really requires a very high level of care. All of us know our children better than anybody else. We are the glue that bind our support network together. We're also in the thick of things and we're emotionally vulnerable. Some, if not most of us, have endured years of trauma associated with challenging behaviors. As such, my presentation will emphasize trauma-informed, family-focused care and services while ensuring everyone's safety. I'm also going to review all the funding sources that are available for our loved ones, as well as making sure everyone, including providers, are kept safe. Finally, I'm going to review how to find qualified providers that have the right level of expertise and experience to join your team, especially those who understand co-occurring mental disorders and trauma-informed care. In my next couple of slides, I will attempt to recap some of what has already been covered by previous webinar series by NCSA. Okay. For those of you who are not able to see the screen, I will describe it to you. It is a scene out of a train station with thousands of people hustling and bustling about. I want you to imagine you were unexpectedly dropped somewhere in this picture. Try to hear some of the noise. Imagine all the movements, activities around you. See if you can smell the fumes, other smells that might be offensive to your senses. Now imagine no one speaks your language. What do you think is your first reaction? How do you get yourself out of this kind of situation? As you know, some people with intellectual and developmental disabilities, including autism, don't have a filter of sights, lights, noise, and smells. People who find themselves in this type of sensory overload attempt to solve a problem. Overstimulation, understimulation, not being able to process all the information that's coming in. Unfortunately, their coping strategies are not always safe. Situations that are completely tolerable to you and I might be very overwhelming to our person of interest. And so their behaviors, aggression, property damage, and self-harm are typically due to years of not having developed healthy ways to get their needs met when they feel a perceived crisis. So in absence of these healthy coping strategies, our loved ones are engaging in behaviors that significantly jeopardize their safety and health of themselves, as well as those who are around them. Our person of interest of any age who has difficulty communicating their wants and needs resorts to using behavior to communicate when they perceive crisis. Communication skills may be insufficient. It may be impossible for them to use nonverbal communication or cues. If they feel ill or uncomfortable, the inability to communicate can also prove even more frustrating. As such, it's really important that we rule out biological reasons for these challenging behaviors. Yet we have such a shortage of doctors who feel comfortable treating people with IDD that basic healthcare often turns into a much bigger, more serious health problem. A challenging behavior can have more than one cause, and these causes can change frequently. Add to this complexity is that home and community-based interventions are often watered down, and effective programming and support doesn't come into the picture until the individual and their family are in crisis. So I will stress the importance of not allowing yourself to get outnumbered along the way. I will talk more about that in the later slides. Best practice guidelines. For those of you who are not seeing what's on the screen, it's a crib mobile depicting access to care. Best practice guidelines recommend remediation programs that are effectively designed and delivered by the medical community, therapy providers, families, schools, other providers, all working well together and achieving consensus and consistency. Much like this crib mobile, if one of these systems is missing or broken, the whole mobile will come skewed and break. So in order for our loved ones with complex social, emotional, and behavioral disorders to thrive, all these systems play an integral and interconnected role. They need school-based health services, which include school-based behavior therapy, neurodevelopmental therapies, and much more. They also need medical and therapeutic interventions that are in theory covered by all forms of health benefits. And for those who are eligible, they also need services that are covered by Medicaid waivers, which can be comprehensive. In addition to that, we need providers that have the appropriate training and experience to work with this population beyond pediatrics and early childhood, which is likely the biggest barrier for our adolescents and adults. And I will talk more about each of these groups in the later slides. NCSA has had several excellent trainings on insurance coverage, so I'm not going to go deep into this topic. I will just remind all of us that Medicaid and private insurance carriers require treatment to be medically necessary before covering it. This means you need to have a doctor with expertise in autism and intellectual and developmental disabilities and complex mental and behavioral health needs, who can then help build a case for support from all of your funding streams. Making a case for medical necessity has to show how a person's symptoms are having an adverse impact on their development and or communication and or demonstrating injurious behavior. This is different than the treatment plan that is developed by specialists. The person who prescribes the care is typically not the same person who delivers that service. Again, I'll talk more about this in the later slides. NCSA has had several excellent trainings on the different laws, so I'm not going to go deep into the topic. Most of you know Medicaid is the funder of all adult serving systems. If you'd like to learn more about the different types of health benefits, you can find more on our website. The one benefit for children under 21 years old is called early periodic screening, diagnosis, and treatment. In most states, the T and the actual therapies are not covered. And in Washington state, our organization reached a settlement in the state of Washington over not just the screening, diagnosis, and evidence-based treatment, but not just the screening and diagnosis, but also evidence-based treatment, including applied behavior analysis and neurodevelopmental therapies. This is for all children with intellectual disabilities, including autism. And then this coverage then became the benchmark for all other states to amend their state plans to cover these services. The other benefit that I want to just touch upon is the Employment Retirement Income Security Act, or ERISA. It's a federal law that sets standards for most health benefits that are offered by the private sector employers. The Department of Labor provides the oversight. Under this, families have the right to file a claim in court after exhausting all internal appeals. Other participant rights include access to plan information, timely and fair process for benefits claims, and access to records. In addition to that, if you live in Washington State, you have a Washington State's Patient Bill of Rights, which says you have a choice among healthcare providers, means you should have access to healthcare providers who have the appropriate training, skills, and experience for the treatment that your child needs. And the adequate network of providers is loosely defined as accessing healthcare providers who live no more than 30 miles away from your home and have the ability to start treatment within 30 days after they're prescribed. Also, if you're protected under Washington State's Bill of Rights, you can request an out-of-network waiver if you demonstrate that there's not an appropriate provider within your area that can see your child within a reasonable amount of time. Then we have two mental health parity laws. Some states, such as Washington and Oregon and California, have state mental health parity laws. And the other one is federal mental health parity and equity, addiction equity. That's a long name. Both of these laws require health insurance and group health plans to provide the same level of coverage for mental health treatments and services that they do for medical and surgical. All these laws require care to be provided with reasonable promptness. So if your person with disability is prescribed care for complex behavioral and mental health needs, and care is not provided within reasonable promptness, the administrators are then out of compliance with these laws. It's not just enough to pay for the service, they're actually obligated to find appropriately trained providers. And if they don't have someone within their network, they need to make an exception and add other providers. I will also highlight that federal mental health parity, not the individual state laws, regulate how your state administers Medicaid. If you're unsure on what your insurance policy covers or doesn't cover, the first step is to verify insurance coverage. You can do this in multiple ways, either calling your insurance company, your insurance case manager, your employer's HR or benefits specialist to see what your insurance plan covers for ASD and other IDDs. You can also request a copy of your plan document. Sometimes it's called a certificate of coverage. If you or your family are working for an employer that has insurance coverage through Medicaid, the most important thing to remember is that coverage is included in all Medicaid and managed care plans. Most therapies and treatments you might need for autism can be accessed through a prescription. Intensive treatment programs require prior authorization in addition to a prescription from an approved medical provider or a psychologist. Our priority is always to keep our family members in the least restrictive environment and to find community placements so that our children won't have to go into an institutional placement. Hopefully, you're not here because your family member is in crisis, but because you want to prevent crisis. I am intrigued by the misconception that respite care is the greatest need for parents and caregivers caring for a family member in their home. I'm also really intrigued that most therapies are often overlooked and not talked about for people with profound autism. At the risk of sounding like a broken record, I will repeat, people with profound autism rarely have access to evidence-based therapies, interventions, and services. And the structure and predictability that's available at school, as well as the care coordination and arranging for medically necessary therapies, are halted once these students turn 22. We as families really can't replicate the structure and the predictability that our children need. It's the absence of these vital services that profoundly autistic individuals develop those debilitating behaviors that jeopardize their health and safety and those that are closest to them. This further leads to isolation and restrictive placements. I'm also intrigued that almost every professional and agency representative and DD advocate that I meet completely overlooks the role of the healthcare system for people with profound autism. Is it therapy? Is it services that they need? If it's therapies they need, you do it this way. If it's services they need, you do it that way. It's not one or the other, it's both. Our family members with complex mental health and behavioral health needs are going to need both. Remember that crib mobile? I said best practice guidelines recommend remediation programs that are effectively designed and delivered by the medical community, therapy providers, families, schools, other providers, all working together, achieving consistency and consensus. Nationwide, we are alerted to the crisis of people with IDD residing in hospitals with no medical need. Often providers and families can no longer support the individual's behavior challenges and left with no other alternative but to take them to an emergency department and then refuse to take them back home. Washington is addressing this by transitioning people with IDD from hospitals to a state-operated rehabilitation center or out of state residential programs for adolescents and teenagers. Families have one goal in mind: finding the best possible treatment that we can find. Whether they're struggling with a mental health issue or a behavioral problems, you want to find a treatment team or a center with optimal combination of therapeutic methods, treatment philosophy, as well as proven effective outcomes. Therapeutic methods should be data-driven. They should be based on scientific evidence. Treatment philosophy should resonate with you. And it should sound like a great fit for you and your sons and daughters. Treatment outcomes should have a verifiable track record of positive results for the adolescent and adult population. Applied behavioral analysis ticks all these boxes. It's evidence-based, has a viable track record of positive outcomes. Having said that, though, just because someone is a licensed and board-certified behavior analyst, it doesn't mean they have the right training background or expertise nor capacity to meet the complex needs of our family members at any age. I will say that behavior analysts who have experience with complex mental health needs, especially in older adolescents and adults, are in very short supply nationwide. Of course, you also want experienced, highly trained team of psychiatrists, neurodevelopmental therapy providers, and support staff. We try our hardest to keep children and adults safely in our own homes, but there are situations when this cannot be accomplished safely in regular schools and at home or in a community setting. The progression then is to look for hospital-based day programs or specialty schools, and I'll speak more into the steps that are needed for eligibility for all these different placement options. Jill, how are we doing with Q&A?
Well, I can go through, there are 3 questions. I'll quickly run through them. First question, just very simple. Will the slides be available later?
Yes.
Sure. Yeah, we do video and slides. We can post both of those on our website. What can I do if my mental health insurer is out of compliance? Oh,
Yeah.
imagine that.
So on our website, we have appeal resources. I encourage you to,
Would you mind just sharing your website,
oh, sure.
Arzu? Yeah.
It's Washington Autism Alliance.org. One word, Washington Autism Alliance.org. And once you navigate there, and at the end of these slides, actually, I will have a drop down. I will go over all of our self-help resources. So stay tuned.
Okay. And one more question. Arzu, can you tell us what you did to help ensure ABA is covered by Medicaid in Washington state for adults?
Yeah.
What do you
So
recommend for states like Washington who have limited and more often no ABA providers who will work with adults with significant challenging behaviors due to lack of skill, expertise, comfort level, and also not paid more to serve this population? So they don't.
yep. So to your first question, the actual coverage came through a lawsuit and a settlement with the state of Washington. We reached that settlement in 2020. And if you, and I will say you're absolutely right about not having an adequate network of providers. If you recall, our first settlement in the state of Washington for private insurance was in 2011. It took till 20, I would say it took another 10 years before we had an adequate network for children, for pediatrics. So I would, this settlement went into effect in 2020 for adults. We are definitely not there yet in building a network, but there's more to this very complex question than making sure people are getting paid adequately. We also need to make sure that, um, and I will address this, we need to make sure that we're not attacking this category of provider. We need to make sure to get in front of all the misinformation that's out there. So I will talk about that in the later slides.
Okay, doke.
All right. So, the all of the or the most salient detail of these intervention programs is the positive behavior supports. And there is much confusion over positive behavior support and whether it's a completely different form of therapy than applied behavior analysis. There's also much misinformation and anti-ABA rhetoric on all forums about ABA. That's a topic for another time. I will just say that positive behavior support is firmly rooted in the principles of applied behavior analysis. For crisis stabilization to be effective, you need professionals across all settings who are qualified to conduct functional behavior assessments and design plans, provide training, ongoing supervision, and consultations to ensure consistency across people and environments. It's this consistency that is most often the weakest link. The inconsistency in our instincts, in our belief systems, how we communicate under duress, and inconsistency in our strategies that maintain most challenging behaviors year after year. There's a highly sought after mental health professional who is a licensed behavior analyst and mental health counselor who is brought in here in Washington when a school district is looking at the last resort for a student that they can safely serve in local schools. She had a funny saying, pick a plan, even if you think it's the wrong plan, but do it consistently with fidelity and stick to it over time. I guarantee it will work. She was right. I've seen it time and time again, how well consistency works for learning pivotal important skills. Okay, the wraparound approach. Wraparound approach provides a holistic view of each person's interactions and supports in different settings, which more fully informs the positive behavior support plan and the individual support plan. Team members are chosen by the individual and the family. They include family members, friends, community members, service providers, school staff, and other service system representatives. We also need access to family systems counseling. For those of you who are not familiar with this term, it's different than getting counseling for your child. It's learning how to work effectively as a family to support the complex needs of your child. Before my husband and I had family systems counseling, we were at each other's throats on how to best get help for our family and children. It was really, really helpful to seek this therapy and counseling for the two of us. We also need predictable routines and minimal unstructured time. We need case managers that are encouraged to identify all natural supports, as well as ensuring culturally appropriate goals, as well as familial or caregiver values. Also of high priority is the health of family members and caregivers. For those of us with multiple family members in our household who have chronic illnesses and special healthcare needs, we are especially vulnerable to crisis. There are no quick fixes for complex mental health and behavioral health needs. There's no magic pill. There's no magic word that will instantly cause the behavior to stop. Effecting behavior change will require time and consistency and the right team to keep everyone safe. Regrettably, home and community-based services are woefully underfunded and inadequate, and they force individuals into an institutional level of care. As an example, staffing ratios. Remember, safety of everyone is always the top priority in any situation. A large person who is in an active cycle of severe escalation, especially an adolescent and an adult in a large body, might need 3 people or more to safely de-escalate and for the minimum amount of physical prompts to be needed to protect the safety of the person of interest as well as the supporting staff. This is what I meant by don't get outnumbered. It's hard to get commitment from payers, whether it's a school district or a health plan or a state, to ensure they adopt positive behavior support programs that are adequately staffed. Please don't be shy to ask to have, when you're going through these assessments, even if it's for in-home support, don't be shy to ask for 2-to-1 support. And that 2-to-1 support shouldn't always include you. Also, positive behavior support programs help prevent the types of behavior that lead adults to believe their only recourse is to isolate or restrain a person. We also recommend including a statement that the placement setting will support its staff, including educational staff and others like bus drivers, lunchroom staff, require training in de-escalation as well as specialized training in responding to explosive behavior that often results in isolation or restraint. Training must happen more than once a year. It must focus on avoiding isolation and restraint and on performing them safely. In Washington State, school restraint is prohibited except when a student's behavior presents the imminent likelihood of serious harm to self and another person. We maintain that restraints are not safe and do not assure anyone's safety. There is no such thing as a safe restraint. Isolation or restraining a person is traumatizing. It can have life-altering effects. Intervention plans need to set the tone for the entire team, making it clear that a pair's philosophy of care and guiding values do not include isolating and restraining except in an emergency, in a true emergency. Care plans require reviews if individuals are subject to multiple instances of restraint or isolation to address whether a functional assessment should be performed to evaluate whether the existing behavior intervention plan should be revised. The assessment should include consideration of positive behavior strategies. They need to revise these strategies to address dangerous behaviors. We hope to promote a cultural change in our schools, homes, and communities that recognizes that to isolate or restrain our children is damaging to them. Without accountability, we will continue to hear reports about children, adolescents, and adults being abused and harmed. I will also say that we have very strict and robust reporting requirements in Washington State. Let's talk about steps you can take towards building a case for specialty schools or partial hospitalization that are typically associated with a pediatric hospital or a hospital. If you haven't already, start consulting a seasoned educational consultant. This could be a psychologist, a PsyD, or an educator who is an educational consultant that focuses on at-risk youth. They have 3 key areas of expertise and experiences. They all have expertise on assessing individuals' social, emotional, and academic needs. Their expertise includes evaluation of academic and treatment systems and direct intervention and communication with adolescents and their families. But more importantly, these educational consultants are typically very familiar with both specialty schools as well as therapeutic boarding schools, and they can make recommendations on placement options. This person will often work with your advocates in order to build a case for either the partial hospitalization or therapeutic boarding schools. You can ask this person to complete a comprehensive needs assessment for your sons and daughters' social, emotional, academic needs. Ideally, they should observe your children in multiple settings, including school, in structured and unstructured settings. Jill, how are we doing with questions? Do you want me to keep going?
Yeah, let's actually take a little break. Someone asks, can you cite an example or a scenario? And I think the question relates to this current slide, to you seeking a placement such as this.
Yeah. So let's say your student has not succeeded or has not thrived, is not making progress in their IEP year over year over year. You have these same goals that they've had 3 years in a row on an IEP, and they're not making adequate progress. They also are experiencing more frustration at school. There are multiple suspensions. You have considered different placement options in the district, and you and the district are either at an impasse, or you're coming to the realization that your student needs something else. School districts, depending on the size and depending on their geographic location, if they have access to more, if they're more rural, sometimes are either unfamiliar or reluctant about looking at options outside of the local school district. This is when having an educational consultant on your side will help you build a case for, let's make a case for looking at a placement in a therapeutic boarding school. Does that answer your question? The person who was asking that?
I don't know if this person is going to come back on. I'm not sure, but I do want to mention that in 2 weeks, our next webinar is, we're planning to have it on the subject of specialized schools
Perfect.
for autism, which would include residential placements. And we are still trying to nail down the details of that. Hopefully, we can get our act together well in advance of the 2 weeks deadline. But if we need to reschedule it, we will. So I just wanted to give people a heads up about that.
Yeah. I see.
And I have another question
Okay.
here. Um, there is, on this very topic, unethical lack of partial hospitalization. Maybe, can you explain partial hospitalization, Arzu?
Sure.
Thank
Sure.
you.
Yeah. Um, a day program in a setting that is part of a hospital is partial hospitalization, where you're not truly in a 24/7, you're not in a psychiatric facility, you're not in a hospital, yet the school program that you're going into is associated with a hospital. An example of that here in Washington State, Overlake Specialty School is part of the Overlake Hospital. The students who get placed there not only have access to their IEP, and teachers that address um, the academic goals, but they also have in this setting access to a mental health counselor, access to speech therapist, access to a behavior specialist. So the placement is part of a hospital, but you're not placed in a hospital. You're an actual student. You get to go home at the end of the school day. You're not, it's not a 24/7 facility, nor is it a hospital. So it's referred to as partial hospitalization.
Got it. Okay. Um, RTC, can you define RTC?
Um, Katrina, you need to put, do you mean RHC?
I'm not sure. But
Okay.
anyway, I'll go on with Katrina's question. Unethical lack of partial hospitalization, specialty schools for our profoundly impacted autism population. What can we do as an advocacy body to effectively grow capacity? You were talking about long term for our highest need population. I work in an emergency department, and we have seen a concerning spike in the profound autism population with SCBs,
Severe
serious, severe
behavior.
challenging behaviors, who are stuck in EDs, emergency departments, hospitals, or sent home unsafe. And the cycle repeats because Medicaid, HCBS, home and community-based services, do not serve this population. And when needs exceed what parents can provide safely in the family home, we are unable to find residential programs who can serve them, or very long wait times. Indeed, that sums up our national crisis in one paragraph, Arzu.
That's right. Um, you will remember at the beginning, I said there are some near-term, short-term solutions. And while we work on systemic, what you're describing is the systemic barrier that exists. What can we do near term? We need to plow away and remember that consistency that I was talking about, and really having people from multiple systems working together. I have heard from you and others that there's often a reluctance to tap into one of the systems of care. And I think it's that lack of coordination amongst multiple systems that drives people into crisis. As an example, I will speak to some of the clients that we've encountered along the way, that there is a philosophical opposition about therapy. And so, in absence of this therapy that's been prescribed, um, the person is not accessing the therapies that they need. And there's sometimes philosophical opposition to medications along the way. And so there's sometimes reluctance in tapping into all the multiple systems of care. I know you're a very savvy um, care coordinator for the clients that you work with. And you're absolutely right. There is lack of all of these programs, we outnumber the people that need the services, far outnumber the number of services that we have. But there are some short-term things that we can do, certainly training by teaching people how to advocate for services at home before they are forced to bring children into an ER. There's a lot of near-term things that we can do, and I'm happy to brainstorm with you along the way to put training just specifically on that. Introducing people to some preventative measures ahead of time. But in the interest of time, I will just say that this is a very complex problem, and we can't appropriately address it in a 1 hour presentation.
Yes, but I will say when Arzu and I were in DC, this was our theme, that through our HCBS waiver system, this particular portion of the autism population is routinely ignored and marginalized and basically not served by the HCBS provider network,
One of the
oftentimes.
one of the questions says, what is a true emergency? I will I will say this is very different for every person. A true emergency is very different for every person. I have had a combination of families contacting me when a family member, a parent, is diagnosed with a very, very serious healthcare condition, and they were the primary caregiver for their family member who had very extensive needs. They had very significant challenging behaviors, and all of a sudden, their primary caregiver was diagnosed with a very serious health care condition. They had to be hospitalized, and there was no one to care for their family member. They had not made plans for where is this person going to live if something like that happens. I would say that's an example of a true emergency. When the person is not able to safely be cared for in their immediate surroundings, and there is no natural community of support. That's an example of a true emergency.
Okay,
Then
why don't you go on, because there are a number of other questions, but maybe it's best for you to get through your slides.
sounds good.
Okay.
Yep, sounds good. Okay, so again, on the therapeutic boarding schools, what are some team considerations? It's really important to consider, has there been lack of reasonable and adequate reduction and stabilization with a partial hospitalization or a specialty school? You also need to have a plan of what are interim placements and recommendations. What is going to get them from their home program or their home school program into a long-term therapeutic placement? Sometimes there's something considered a wilderness program for some of the therapeutic boarding schools. It's completely inappropriate for the population that we're talking about. So there needs to be an interim placement that's appropriate for someone with profound autism. And then what characteristics are appropriate in a long-term therapeutic boarding school? There are a lot of boarding schools that are so inappropriate for the population that we're talking about. There are a lot of therapeutic boarding schools that focus solely on group instruction, group therapy, and talk therapy. That's completely inappropriate for the population that we're talking about. What will a step down program or transition to a least restrictive environment entail? If the placement is in a therapeutic boarding school for a child with profound autism, oftentimes we don't have a less restrictive environment. And so if that's the placement that you're going towards, along the way, don't be intimidated by the idea that there's this pressure to bring them back before they're prepared, before they're ready. Also, who pays? So school districts, for someone who's under 22, school districts are the ones that pay for these therapeutic boarding schools, specialty schools, and partial hospitalization. This often requires involvement of a special education attorney. Health plans will pay for the medical, behavioral, and neurodevelopmental therapies, even in these specialty schools, but they're not going to pay for the education side of things. They're not going to pay for an academic side of things. And then Medicaid waivers are not going to pay or cover what they consider an out-of-state institutional placement. Contact us separately if you need recommendations for these types of placements. Intermediate care facilities for individuals with intellectual disability, it's ICF or ID for short, is an optional Medicaid benefit that enables states to provide comprehensive and individualized healthcare and habilitation services to individuals to promote their functional status and independence. Although it is an optional benefit, all states offer it, if only as an alternative to home and community-based services waivers for individuals at the ICF ID level of care. Eligibility for ICF ID benefit is available only if the individuals in need of and receiving active treatment services. Active treatment refers to aggressive, consistent implementation of a program of specialized and generic training, treatment, and health services. Active treatment does not include services to maintain generally independent clients who are able to function with little supervision or do not require a continuous program of habilitation services. States may not limit access to an ICF or ID service or make it subject to waiting lists, as they may for home and community-based service. So in some cases, an ICF or ID services may be more immediately available than other long-term care options. Many individuals who require this level of service have already established disability status and Medicaid eligibility. There are some state variations. The need for ICF is specifically designed by steps, all of whom have established an ICF ID level of care criteria. State level of care requirements must provide access to individuals who meet the coverage criteria that's defined in federal law and regulation, in addition to the level of care for active treatment, and the need for active treatment must arise from intellectual disability or a related condition. The definition of related condition is primarily functional rather than diagnostic, but the underlying cause must have been manifested before age 22 and likely be continued indefinitely. States vary in practical applications of the concept of the related condition. In some states, individuals applying for ICF ID residence may be eligible for Medicaid under higher eligibility limits used for residents of an institution. And then services that are included in an ICF ID benefit, it provides active treatment, which is a continuous, aggressive, and consistent implementation of a program of specialized and generic treatment, training, and health or related services directed towards helping the enrollee function with as much self-determination and independence as possible. And ICF ID is the most comprehensive benefit in Medicaid. Federal rules provide for a wide scope of required services and facility requirements for administering these services, and all services include healthcare services, nutrition as part of the active treatment, which is based on an evaluation and individualized program plan. It's done by an interdisciplinary team that includes parents and caregivers and private providers. Facility requires include staffing, a governing body, management, client protection, client behavior and physical environments, which are specified in the survey and the certification process. Another really important component, day programming. Many ICF residents work in the community with supports or participate in vocational and other activities outside of the residence. They engage in community interests of their choice. These activities are collectively often referred to as a day program. The ICF ID facility is responsible for all the activities, including day programming, because the concept of active treatment is that all aspects of support and service to the individual are coordinated towards specific individualized goal in the individualized habilitation plan. Where are they provided? They are only available in a residential facility licensed and certified by the state surveying agency. These services are available only when other payment options are unavailable and the individual is eligible for Medicaid. There are few resources like an ICF ID under any other payment source. This is the costliest, most comprehensive and coordinated level of care. As such, in my experience, it's one with the lowest capacity, meaning the least number of individuals are served there. But if you have exhausted all community-based options and your family member meets this level of support, I encourage you to educate yourself on ICFs. Okay, now our self-advocacy tools. For Washington State residents, as well as the rest of you, you can find our self-advocacy tools on our website. We want to make sure you can find these resources after today's conversation. You know how you're not supposed to put really teeny tiny font on slides? Well, I failed that miserably. So I will read. Some of our topics are autistic burnout versus depression, adults navigating diagnosis. These are our training workshops, by the way. So they're the self-advocacy tools, starting with training workshops. Training on Developmental Disabilities Administration, the ABLE account. We also have the Autism and Law series. We have these signature trainings that are really comprehensive, special education training. And then we have some autism and insurance, how to maximize your health benefits. And we include understanding ABA. We have an education law library. Some of the topics include ABA in schools, academic failure and regression, discipline or removal, discrimination, civil rights, bullying, dispute resolution, district transfers, eligibility, emotional behavioral support, evaluations, general information and referrals, homeschooling, hygiene, compliance, language access, parent participation, placement, inclusion, related services, restraint isolation, as well as transition programs for 18 through 22. And then we have an insurance portal that provides information on how to maximize your health benefits, whether you get private insurance or Medicaid. And then we also have a resource directory that has some providers by each category. We have some adult programming, advocacy, financial, and legal, autism diagnosis, behavioral health and mental health services. This number next to the category is the number of providers that are listed in each category. We have educational programs, health services, neurodevelopmental therapies, recreation, other services, and support groups in the community. With that, I am done with my slides and open to any questions and comments.
Thanks so much, Arzu. There's a lot in there and there's a lot of questions and comments. So let's go through as many as we can here. Somebody I noticed in chat, you were talking about restraints and isolation. Definitely, obviously, those should be last resort. But that, some people commented sometimes they're needed. I've obviously had to use restraint with my own son to keep him from hurting himself or others. Didn't love to do it, but it's better than the alternative. If you have some comments on that.
I do. I absolutely do. And so if you remember, I said it is when a person is at risk, at imminent risk of harm to themselves or others, it absolutely is needed. However, the person needs to have training on how to do it safely, and it needs to be done in a way that's not traumatic to the person. But no, I completely agree with you. If a person,
not all restraints are created equal, right? I mean, some restraints are clearly very dangerous, right, and shouldn't be done. Others are benign. Yes.
You have a child who's about to run in the middle of a street. you need to block them. You don't need to restrain them. You don't need to tackle them to the ground. You do need to block them from running into the middle of the street. However, if you have a person who is dead set of jumping off of the roof of a building, they've climbed up there, you need to find a way to hold them safely before, and not allow them to jump off. That's a life-threatening situation. So in life-threatening situations, in a situation where a person is posing serious risk of harm to themselves, you need to stop that from happening.
Yeah. Okay. Somebody is asking, is there a place in Western Washington that offers partial hospitalization for kids? Her son is 10 years old, sadly currently at Children's Hospital PBMU for aggressive behavior and mental health crisis. How horrible. I have not heard of anything like a halfway point of partial hospitalization.
If you're not in touch with NAC, Northwest Autism Center, that would be, I think, the best resource for Eastern Washington. They offer, I do believe they have early childhood themselves. They offer an intensive day program, but they might know of local resources in Eastern Washington.
Okay, lots of chat about ICFs, ICFs being sometimes more available on paper than in reality. And Katrina mentions that some states pass laws to restrict placement in ICFs for people under a certain age. In Washington, the age cutoff is 16, which has resulted in a growing rate of out-of-state placement for our younger aged, kids requiring an institutional level of care. And it costs more to send them out of state. Sigh.
I don't know that it costs more to send them out of state.
Okay.
From what I've seen from the cost data, I'm
But
just, I'm,
what do you have to say about the age restrictions on ICFs and the fact that ICFs, kind of you read about them in the statutes, you see them listed on the web, certain websites, but access to them seems very, very restricted.
yep. There is a significant philosophical opposition to placing people in an ICF.
And tell me about when you say philosophical opposition, what are you talking about?
I am talking about advocates, self-advocates, um, people who historically were placed. Historically, I'm talking about in when these institutions were first created. We're talking decades ago, 70 years ago. I think our ICFs were the oldest one goes back to the 20s, right? So we're talking about like 100 years ago, 80 years ago, when these institutions were first built, any child was placed there. And so we did have a large population of people who could live safely in the community and have transitioned out from an ICF. In addition to that, there is, when I say philosophical opposition, there is this mindset that everyone's needs could be met in the community. People can live, play, and work in their community of choice. Everyone is employable. Everyone can get education in their local schools. Everyone should be fully included, right? These advocates, with the best intentions, have advocated heavily against an intermediate care facility. And so funding over time has been taken away from ICF facilities. The programs have become watered down. In many states, they have either closed or they have downsized. So there is a philosophical opposition to an intermediate care facility. But but that has done to people who truly need it is there's this long wait list to put children in a place like Kennedy Krieger in another state, or families really at a very young age, as young as 11 years old is what I know in Washington, have to place their children in another state. To me, that's more traumatic for a child to be placed in another state and not have access to their parents for visitations, but months and months in between. So that to me is more traumatic for both the child and the family.
Okay, yes. ICFs, when people are looking for an ICF, do they go to their Medicaid authority? Like what's their route to even get there?
Yeah. So remember, go back to the eligibility slide. Your family member must meet eligibility for an ICF placement. In other words, they are not successfully being served by the existing group home, family home, supported living, supported employment. There is a long documented history that the person has been turned down by all of the community placements. Um, the person has been turned away by all the supported living agency. The person has been turned away by all of the employment agency. They're not able to participate in any day programming or any respite care programs without one or two people always facilitating that. That's the person who meets eligibility. Once they meet eligibility, I would say having an MD, the same way that you built the medical necessity case for another really expensive therapy, the same building a case for medical necessity needs to be made for an ICF. The active treatment element that's only available in an ICF, you need your doctor's help to build a case that active treatment is absolutely vital to your family member. Without it, they're not able to make progress in any other setting.
Thank you. Okay. A lot of questions. Um, Very general question here. What do you think is the reason for the tremendous shortage of staff, from aides to teachers to doctors to mental health providers, to work with our family members with severe IDD and autism?
So, a couple of things I've noticed. If we're not accounting for the person's age and size, let's say we set aside the fact that some of our family members have historically have been more difficult to work with. I've noticed that since the pandemic, the pipeline of workforce has become really uh, constrained. It's the pipeline of people who were going into working with people with intellectual and developmental disabilities in schools, people who were going into um, behavior fields, that pipeline has gotten smaller and smaller and smaller. I think young people are able to build a profession in other creative ways. And so overall, the pipeline of educators has gotten smaller. I see this in general education teachers. I see this in speech and language pathologists. I see this in all of those professions. Add to that the misinformation about some of the people who were historically providing behavior support to this population. There is so much bashing of behavior therapy and behavior change, behavior modification. There's so much bashing of you must not change behaviors. You have to accept people the way they are. You have to only provide accommodations. This is all, I think that has had also something to do with the pipeline of providers going into these fields. So I think it's a combination of those. Also, the pay scale. I think the pay scale really has not kept up with inflation. Cost of living has gone up so much in our area. In my region, bus drivers get paid way more than paraeducators, way more than behavior, at least like $10 an hour more. So do you want to be a bus driver, or do you want to go work with a really difficult student in a classroom? I think I'd rather drive a bus. Sorry, I'm sorry.
Yeah. No, that's exactly what happens. Like here in California, we're paying fast food workers, right? More than, people who are working with sometimes aggressive and, challenging children and adults. So which job do you choose?
Bus
Okay.
drivers are getting $33 an hour. Paraeducator is getting $21 an hour to work with a really challenging student. So it's,
Yes. It's a systemic problem. Nobody, there's so many questions. I will save my diatribe later. Okay, we are currently in crisis and working with our state's developmental crisis team in Idaho. Where can I find an educational consultant? The developmental crisis team seems completely of the opinion that this cannot happen. I think what you mean is some sort of placement cannot happen. I'm not sure exactly what she means, but
So I would say find a person like me in Idaho who is part of the national, either National Autism Law Summit or is familiar with educational consultants in your own state. I can provide you with lists of people who live in near the border of Idaho, but I think it's really important for you to find someone in your own state. If you're not able to find someone in Idaho, contact me offline and I will provide you with names of educational consultants in Washington State who have experience with IDD. Here near us, there's a neuropsychologist who travels around the nation and has visited all the different placement options. And she's somebody that I feel very comfortable referring individuals to.
Related to our previous talk, a comment, care providers, health, therapy, in-home, group home, etc., outright refusing to provide services to those on the profound severe end of the ASD scale because such clients require intensive and costly needs. This is the same theme. This is what we were talking about when we went to Capitol Hill, which is, yeah, boy, we call this the empty waiver problem, right? That, well, you have the waiver, but none of the agencies will accept your kid as a client. So you can't actually use the waiver. And, that we see as a form of systemic discrimination and a real loophole in
I
how we think about HCBS services. And this is something that NCSA is really gravely concerned about. And anyway, you can go ahead and
I
talk, Arzu.
completely agree with you. However, it's really important for us not to think of our caregivers as behavior support providers. The people who refuse to work as a caregiver when they're put in a situation where they're expected to be a behavior tech is when that person is going to refuse to do this type of work, right? And so you need to be careful what you're asking of a provider. If you truly just need a caregiver to provide respite care, then making sure that they're staffed appropriately. So making sure that your care plan is asking for like two of these folks being available at the same time. If your family member has a pretty significant challenging behavior, I find that for us, and you remember at the beginning, I said our family member has a long history of severe challenging behaviors. The worst situations where if we relied on a caregiver and an attendant care provider or a respite care provider to attempt to take our son into situations where they really needed to be two people, and one of those people needed to be a behavior specialist or a behavior technician. So I think that we need to be clear what we're expecting people to do when we're seeking their help.
But the behavior technician is covered, should be covered under Medicaid. I mean, so it's part of the same puzzle.
Right. In Washington State, they are covered. If you're in a state where the behavior technician is not covered by either Medicaid waivers or Medicaid, let's brainstorm together. I'm happy to brainstorm with you offline.
All right, Arzu. Someone comments that ICFs do not have trained staff for severe autism and behaviors here in California. They only accept clients with physical, mental needs that require active care, but not designed for our population.
So that is really unfortunate. If you read over ICF regulations, which I have, very few people have because the entire population in the nation there are not very many people who are served in these ICFs. If you read over the regulations, it very much is designed for our population in mind. Intensive behavior support, therapies, Just because it's prescribed on paper, though, doesn't mean the states are providing it with fidelity. Um, I will say, without going into too much detail on a recorded conversation, if you find yourself in a situation where what is required under statute is not provided, then you need to appeal that. You need to appeal the fact. That means you need to file a complaint that the services are not, the services that are medically necessary are not provided. And I am happy to brainstorm with you about that offline. It's something that I'm very passionate about.
Someone asked, do you have a list of family system counselors that specialize with a profoundly severe adult with autism?
In Washington State, I do, not in other states.
Yeah, that's something I'm not very familiar with.
So this is typically a mental health counselor that has worked with individuals and families from early childhood through the lifespan, and not only understands marriage and family counseling, but they also understand profound autism. That's a person who not only understands the needs of this person that you're caring for, but also understands the stressors on a family and teaches you skills, coping strategies, and really helps you work effectively together as a family unit.
Mm.
Um, some people claim to offer this, but it's typically either a psychologist or a neuropsychologist or a mental health counselor.
Okay, we are past time, so I will close with this comment from Katrina. Arzu, you are amazing. Deep gratitude for all you do in Washington and across the country. A tireless, effective, and persistently pleasant champion. I can attest to that. You're very pleasant. And she's a great walker, by the way. She puts the rest of us to shame.
Humidity and 85-degree weather, that's me.
So, Arzu, thank you so much. It's a big topic. I know we could have gone on for hours about crisis care, whether it's in-home or hospitalization or school related or ICF related, and in this whole universe. And we only had a limited amount of time. Perhaps we can return to this topic, maybe more focused, on a subset of issues, just to more deeply probe. But thank you so much for everything. We will post the video. Arzu will send me the slides. We'll get everything up on our website. And I thank you very much. Arzu, any closing comments before we bid adieu?
Thank you for this opportunity. I have really enjoyed working with you, Jill, and some of the advocates that I recognize in attendance. If there's anything that resonates with you after this conversation and want to contact me directly, my contact information is on the slides.
Perfect. Okay. Thank you, Arzu, and good night, everybody. We'll hopefully see you in 2 weeks with this webinar about school placements. And as soon as we get that finalized, I will post it on the website and Facebook. Okay. All right. Bye.